gotten requests for recording.
We both of the ASL interpreters are here. Can you hear me?
Yes.
Okay. Can you make us co-hosts so we can pin each other?
Yes.
Thank you. Okay, great. Where's Elliot? There we go.
Claudia, did you see that Vanita Gupta got appointed to be the Associate Attorney General?
I did. I'm very happy about that.
That's exciting.
I also texted you a last minute request.
Oh, sorry, I'll look.
Would the second ASL interpreter mind putting ASL in front of your name so we can find you?
I'm waving and I'll do that, but it might be easier for you to find me with me waving. And
Or just tell us your name, actually.
Elliot,
Thank you.
thank you.
This is Christina from CFILC. I just quickly want to let people know that we apologize in advance. We have reached capacity for today's town hall via our Zoom account, but we will certainly increase it beyond the 100 max next time. I am getting text messages from folks right now saying that they can't get in.
So we should be able to have 500. So let me figure out what's wrong.
Great. Thank you, Jessica.
And Claudia, I'm happy to do the thing you texted me about.
Thank you, Andy.
And is this being recorded so that it could be made available to those who are unable to attend?
Yes.
Fantastic.
Also, is it maybe on like a Facebook Live or a YouTube Live that people can get in there? Maybe.
Yeah, are people comfortable with doing live stream on Facebook?
Jessica, I'm comfortable doing anything you want to do to reach more people.
Okay.
Yeah, I'd say just do it and then we can let people know and you won't have to worry about changing the max.
Are you able
so
to do
it's-
it both within Zoom?
Yeah,
Yeah.
Zoom transfers.
So it's going to
over
be
Facebook.
on Senior and Disability Action's Facebook page. You can go ahead and direct people there. I'll give you a link as soon as it's set up, and then you can also share the link on your pages.
Jessica, I'm impressed with your Zoom skills.
Well, I think I messed up the size, so don't be too impressed.
And this is Carol, the ASL interpreter again. Do you know if there will be deaf attendees? I just want to, if we know who they are, I'd like to pin them as well, but it doesn't matter really.
You can put it in the chat.
Or maybe you
Okay.
could ask too. If there's
Do you want deaf attendees to wave? I'll ask them to wave and you can put that in the chat.
I just want to make sure that if they have a comment that I can see them and I know where they are. That's all.
I'll put something in the chat.
Thank you.
And Carol, you're also currently spotlighted for all, so everyone
Oh,
should be able
cool.
to see the message
Okay.
you're
So they can
conveying.
see me. Okay,
Should be.
that's good.
I think this is the right thing to do also.
Okay. Yeah, thank you.
But we'll be switching off every 20 minutes,
Right.
just so you know. How can we do you want us to let you know when we're switching so you know who to spotlight?
Thanks. Yeah, I'll chat you momentarily
Okay.
if that's okay.
Thank you.
Jessica, do you want me to start?
Give me just a moment.
Sure.
There's definitely still a lot of people trying to get in, so I think we should wait a couple minutes once the Facebook thing is set up to send it to people.
Yeah, and those of us that are co-hosting, if we can If you have the ability to simultaneously use another device to share from the SDA Facebook page onto your Facebook page, that might increase the participant number. I'm going to do that right now. It's live currently on Senior and Disability Action.
So it's actually, oh my goodness, I'm so sorry. Let me fix it. I accidentally did it on my personal page. That's not helpful.
I've also heard that people might be able to call in even if the Zoom is at capacity. I don't know if that works, but
No, they tried that. The call line is also at capacity.
okay.
I'm also seeing people periodically in the waiting room that I'm admitting, but it's only a handful.
Claudia, it appears that when you do that, it knocks somebody out, just so you know. I've gotten a text saying that they were knocked out.
Well,
Is
that's
there a
not
way
good.
to give us a link to the live stream, Jessica?
Yeah.
Before we officially get started, welcome. This is Christina from CFILC. We will be keeping a copy of the chat. If you'd like to introduce yourself and have the ability to use the chat feature in Zoom, or if you're joining us by Facebook and want to let us know that you're with us today, we'd love to know who's joining, and if you represent an organization or a group, please let us know that as well. We'll get started momentarily.
Okay, I believe we're live. If someone else can get the link.
The
here we
link
go.
is now in the chat. Steve K has posted it for us.
Perfect.
Are we good to get going?
Claudia,
Yes.
you're up.
Okay. Good afternoon, everyone. My name is Claudia Center. I'm with Disability Rights Education and Defense Fund, and I'm here as part of a large coalition of disability, older adults, and higher weight advocates who are working in the many important issues that are arising around the COVID-19 pandemic for our communities. And I want to welcome you to our meeting today. We are going to try to review what is going on for our communities and our advocacy around vaccine allocation, crisis standards of care, also known as rationing, and visitation policies or modifications to no visitor policies for disabled patients. I want to acknowledge that this week has been extremely painful as well as joyful regarding our the Georgia Senate election, but very painful to see the display of violence and the situation in Washington. So it's been a strange week. And at the same time in California, the pandemic is surging throughout the entire state, as well as in particular in Southern California. And I'm sure we have people from Southern California here today. So I'm glad you're here with us on this strange week. And I'm going to turn over the meeting for a moment to Jessica, who's going to go over some logistics. Thank you.
Thank you, Claudia. My name is Jessica Lehman. I'm with Senior and Disability Action and the California Care Rationing Coalition. Welcome to everyone here today. And I apologize for the technical difficulties. We may have worked out the large meeting issue. If somebody wants to try that again, that's the only way to see if it's working. But again, I hope folks can watch on Facebook, and we will share a link with all registrants afterwards, and we can share it widely to watch the recording. So I wanted to just say a couple things about logistics today. So we're doing this as a Zoom meeting rather than a webinar, which we find is a nice way for people to know who's on and be able to interact in the chat. For accessibility, we will read key information from the chat out to folks. So if it's not accessible to you to follow, you can feel free to ignore it, and we will share important notes later as well as during the meeting. We will keep people muted except for when we have some time for question and answer at the end. We do invite people to show your video if that works for you. It's nice to see who's here if that's accessible as well. And we will be spotlighting our ASL interpreter. If there's any issue being able to see the interpreter or any other access issue, please put something in the chat, or if that doesn't work for you, then unmute yourself and let us know. Please only if that's urgent and you can't do it in the chat. We have captioning, which I should have said earlier. If that is to access the captioning, go down to the bottom of your screen and you'll see 3 little dots and it says more. You may have to make your window big enough for that to show up. And if you click there, you can choose show subtitle. You can also go to view full transcript and it'll show the whole transcript of the meeting, and we will also share that afterwards. I think that covers it. I'm going to ask Peter to remind me if I missed any important Zoom notes or access notes. Okay.
No, but I can share the list of shortcuts in the chat momentarily. Keyboard shortcuts.
That would be great. Thank you. Oh, and good news. I see we have 113 participants. We solved the large meeting issue. So please let people know, and I will let registrants know as well. They can join now. And of course, they can continue to watch on Facebook too. Thank you.
This is Claudia again. I'd like Andy to speak for a moment about how we got to where we are today.
Sure. Thank you, Claudia, and thank you, Jessica and Christina and Brandy and all of the folks that organized the event today. I am Andy Imparato. I am the Executive Director at Disability Rights California. I started in that role in February, so it's been an interesting first year. You know, I think the big things that are worth mentioning in terms of how we got here, the state of California Department of Public Health came out with some guidelines, some draft guidelines in April for crisis standards of care, and we'll be talking a lot more about what that means. But it's basically how you make hard decisions about how to ration things like ventilators when there's more people who need them than what you have in your supply. And the disability and aging communities and other communities represented on this call came together and said, these draft guidelines are discriminatory. They're basically saying you can deny somebody a ventilator if they're too disabled or too old, and that's a violation of federal civil rights laws. So we advocated with the state. The state acknowledged that there was a problem. They came out with new standards in June. None of the hospitals in the state have really been using rationing, at least officially, but now we're at a point with the surge where we think it's much more likely to happen. So with a lot of advocacy, the California Department of Public Health has asked the state, has asked the hospitals around the state to actually post their standards. That's something that we'd asked for since June. So now that's supposed to be public as of Wednesday. And we wanted to do this forum really to create an opportunity for folks across California to learn about your rights, to not be discriminated against, learn about what's happening with vaccines, with monitoring, healthcare rationing, and crisis standards of care and hospital visitation. So Claudia, I hope I covered everything that you wanted me to cover, and I hope I didn't take too long in doing it.
Thank you, Andy. Sorry, I'm having trouble with the Zoom on my end. The next, we're going to have some folks talk about where we are with the vaccination and vaccine allocation. And so I'm going to turn this over to Denny Chan with Justice and Aging.
Hi everyone, thank you so much, Claudia, and a big thank you to all the organizers for putting on today's event. My name is Denny Chan. I'm a senior staff attorney at Justice and Aging, and wanted to echo some of Claudia's comments earlier about how weird this week has been and how it's affecting everyone. And so wanted to echo that before I sort of launch into what is a meaty topic of vaccine and vaccine allocation. I'm intending to do a pretty high level overview of where we are. There's obviously a lot that's happening with vaccines and really everything related to COVID that there's still much that is up in the air or a lot of questions that we don't know the exact answers to, but we're gonna try and give you as much information as we possibly can in this first segment about vaccine and vaccine allocation. So a couple of high level themes in terms of where we're at. One is that the vaccines are obviously something that we don't have enough of for everyone who wants it. So across the country, we are using a phased approach to vaccine allocation. And I think one of the biggest questions that you might be wondering here today is, when am I going to get my vaccine? What phase am I in? And so we'll talk a little bit about what the phases are so far and what we are looking forward to in the future. From a broad level, the CDC, the Center for Disease Control, has issued recommendations to states, but as many things in this country, federalism works such that states ultimately have lots of discretion in how they allocate all the doses that are coming from the vaccine manufacturers. California has set up several different work groups to get input in figuring out what the allocation looks like in our state. There is a safety review work group that is comprised of a number of clinicians across the Western states, including California, that is doing its own separate review of all the different vaccines before they're used here in this state. There is also a drafting guidelines work group, and that work group is the one that's actually putting together what the allocation guidelines look like for the state of California. So who is going to be in what phase and what priority is given to which group. And then last, but certainly not least, is a community vaccine advisory committee. And this group is tasked with giving input to the state and to the drafting guidelines work group and discussing messaging and outreach. And there are a number of representatives from organizations today that are present on the community vaccine advisory work group, such as Justice and Aging, such as Disability Rights California, et cetera. And so that group is meeting sort of every 2 weeks to get input to the state. But as I said before, there's still a lot that is up in the air. There's still a lot that we don't know answers to. And so we are very much in the process of building the plane while we're flying it. So let me get some background on what the vaccines are so far and what the allocation has been so far in terms of process. The first is, as many of you probably already know, the Federal Drug Administration has approved for emergency use authorization 2 COVID-19 vaccines, one created by Pfizer and the other created by Moderna. Both vaccines went through 3 stages of clinical testing and full FDA review. They were also separately and independently approved by the Western State Working Safety Review Group here in California and on the West Coast. Both of the vaccines require cold storage, and in particular, the Pfizer vaccine needs to be stored at sort of atypical cold temperatures, which does complicate the logistics of getting the vaccine out. Each vaccine, according to FDA recommendations, needs 2 shots to be upwards of over 90% effective. The science is not clear about whether the vaccines prevent transmission of the virus to other people. And it's also unclear about how long immunity lasts once you are immunized. Okay, so let's transition a little bit, and we're going to get to talking a little bit later about what you can do in this process to make sure that your opinions and thoughts are heard. But let me talk to you a little bit about what allocation has been like so far in the state. So the state is issuing guidance for local health departments in terms of an allocation framework about who should be prioritized in getting the vaccine. Distribution and allocation happens at the county level with the local health department. Currently, as of today and since December, late December, we are in what's known as phase 1A of the distribution process. So phase 1A includes in our state long-term care facility residents and workers, as well as medical workers. I will note that for the long-term care facility portion, that is largely being handled through a federal partnership with CVS and Walgreens. And so the local health departments are involved, but the actual administration and all of that, getting the vaccines to the long-term care facilities is being handled by CVS and Walgreens. If you're joining us from Los Angeles County, you have the distinct honor of being in the county, the only county in the state, that decided to pull all of its facilities out of the federal partnership. So the local LA Department of Public Health is working directly with the facilities on distribution and allocation on a facility by facility level. But if you're joining us outside of LA, odds are that the facility you're thinking about is registered for the federal partnership and working with CVS and Walgreens. The long-term care facility portion has, in and of itself, it's complicated and has two phases. The first phase is for skilled nursing facilities, and the second phase is for assisted living and residential care facilities for the elderly. It's our understanding that the second phase has already been activated and will begin in the state in the next few weeks. As you can imagine, there are a number of challenges that have occurred over this time. As we already have seen, the uptick has been slower than anticipated, and that is true both in California, but also across the state. Currently, the state has a new goal of vaccinating 1 million people this week and next. So we're in the middle of that goal, and we'll see how far we get. In terms of who falls into what phase. So I said earlier before that 1A includes long-term care facilities and frontline medical workers and people in the medical sector. In the toolkit, you will find a link to the specific guidance for phase 1A from the California Department of Public Health. And if there's a lot in there, so I encourage you to review that on your own time. I'm not going to take time to walk through it piece by piece, but I will say that a couple of things just to highlight it. One is that the specific types of facilities have been sub-prioritized into several tiers. One thing to note is, that if you are at all have any relationship with home health or IHSS in home supportive services, is that is part of phase 1. It's part of phase 1, specifically phase 1 tier 2 for IHSS workers. And then the other thing I will note is that we in the Community Vaccine Advisory Committee worked really hard to make sure that equity was part of the allocation framework. And so you'll note in the 1A recommendations that there is language saying, and I'll read it because I think it's really important language, doses should be prioritized to facilities serving the greatest population of vulnerable persons in their catchment area, as measured by the Healthy Places Index or comparable health department knowledge, followed by facilities serving fewer vulnerable persons. So there really is a focus on making sure that those who are highest risk are really prioritized in the allocation framework. That's 1A, and we're going to be in 1A for a while. But as you know, part of building the plane while we're flying it is thinking about the future. So there's already been planning underway for phases 1B and 1C. And I will take one quick note that if you're at all talking to people in other states, each state is coming up with its own framework. They're using the federal framework as a starting point, but largely states have some discretion in figuring out what its own framework will look like. So what I'm talking about is the California framework. So 1A, we've talked about. For 1B and 1C, what we know is this: it gets even more complicated because we are such a large state. So 1B has 2 phases, and 1B overall is meant to immunize older adults and those who are higher risk for COVID-19, as well as other essential workers who don't fall into the medical sector. So 1B phase 1 includes individuals who are 75 years and older, and then people who work in the following sectors: education, emergency services, and food and agriculture. I will note that when we're talking about essential workers, the state has employed a sector by sector approach. So it doesn't necessarily matter what your job title is, but what sector you're working in. For 1B phase 2, after all of the people in phase 1 have been vaccinated, or most of the people in phase 1 have been vaccinated, there's also people who are 65 years and older, and then the following sectors: transportation, logistics, industrial, manufacturing, residential, I think I said manufacturing, incarcerated services, and services for people who are homeless. After we get to 1B, we get to 1C. And 1C is people who are 50 years or older, or people who are 16 to 49 years with underlying medical conditions or disabilities, and then the following sectors: water and waste management, defense, communications and IT, financial services, government operations, and community services. I will note, you might be wondering, because I was wondering when I saw this, what counts as a medical condition or disability? That largely has not been precisely determined yet by the state. There is a list that the CDC has come up with, but the state is going to start with that list and then going to kind of figure out if there's more input or more to be added there. So that's kind of a to be determined in the future note. A number of groups involved in this coalition made recommendations to the state that in 1B, it should prioritize all home and community-based services users. Unfortunately, well, and I should say there are a lot of pros and advantages to that approach. Number one, it ensures that a lot of people, maybe not everyone, but a lot of people who are high risk would be captured in that population. Number two, for individuals who are on Medicaid HCBS programs, the state has a lot of information about who those people are. And so they're easier to reach in some ways. Unfortunately, that recommendation was not taken into account. But it's not too late, and I think Russell's going to talk a little bit about what you can do to make your voice heard on this issue. Because as much as the state guidance matters a lot, the rollout will also fall on a county by county level. So there's really a lot of input that you can give on a county level, on a local level, about what you think the allocation should look like where you live and in your community. And then finally, I will say, you know, the state recognizes that they've set forth a very complicated framework. If you were not confused by what I just said, then you are smarter than I am, because I was confused learning it. But what I will say is that they are trying to put together some tools to help people figure out what phase they might fall in. So there's currently a hotline that exists for COVID-19 across the state in general, and then there is a drop down or like a subline where people can ask questions about vaccine allocation. And they are putting together, they're putting together an online tool to be able to help people figure out what phase they might fall in. But all that said is that there's a lot to be figured out, and there's clearly a lot that's changing week to week. I just saw, earlier today in the news that the incoming Biden-Harris administration wants to release more doses of the vaccine so that more people can get them instead of holding them for the second dose. So some of this, in terms of who's going to fall into what phase and when that phase will start, will change over time. And what we're working with right now is 2 approved or authorized vaccines. If a 3rd vaccine gets authorized, that will also change some of the timing pieces here. But I know I've said a lot already. So what I'm going to do is turn things over to Russell, who is going to make this really, really concrete for you about what you can do to make sure that your voice is heard during this process.
Denny, this is Claudia. Can we do a couple of quick questions from the chat for you, and then we'll do the Russell?
Sure.
Can you
Claudia?
And I will say I've been ignoring the chat because I was looking at some of my notes, so I have no idea what people have been saying in the chat.
Yeah, no, there's just a few questions. So the
Claudia,
first,
before we do that, I forgot to announce Spanish interpretation. Very sorry to interrupt. Lo siento, olvidó hablar de interpretación en español. Si lo necesita, hay una opción de interpretación o díganos en el chat, por favor, si necesita. Gracias.
so thank you, Jessica. One question for you, Denny, is where do people find the hotline?
It's in my notes, so I will put the hotline number in the chat when I pull it up.
Okay, great. Second is
And I will say this though, I will put it in the chat, but with the big caveat that I asked the state who is answering the hotline and their training. So take it with a grain of salt. I don't think that they ultimately should be or are the arbiter of who falls into what phase. And it sounds like someone beat me to it. They found the hotline. But my note still stands that I don't think that you call the hotline and you get you're in 1B tier 2. That's not ultimately, this is that's a state hotline run by state staff. Again, a lot of these decisions are rolling out on a county level. So please keep that in mind. And if you have reason to think that you should be in a earlier phase, the hotline is not going to be the final say in what phase you are in.
Okay,
it is
great.
merely a tool that the state has put together to try and help people sort some of this stuff out.
Great. And what about hospice companies? How do they fit into this allocation?
Yeah, so if other folks on the community advisory committee remember, my sense was that they fall in 1A, and I can't remember specifically if it might be in the guidance from the CDPH website. I can't remember what tier they fall in 1A, but I'm pretty sure they were in 1A. I'm getting some nods from my fellow advisory committee members. So I would direct you to the link that the CDPH has put together in tiering tier 1, 2, and 3. And we might be able to figure that out too in the back end and put the answer in the chat too.
And this is Christina from CFILC. That is correct, Denny. Hospice workers would fall under the tier 1 of the phase, I believe, is what I have in my notes. So correct.
And then I think this is the last question for now, is that one person chatted that they've heard of people who aren't healthcare workers or long-term care facility residents getting vaccinated in California. And is that happening? And if so, why?
Yeah, this is an ongoing issue that we at the community vaccine advisory meetings have been talking to the state about and raising with them. And will continue to be an issue as we roll into phase 1B, quite honestly. 1A is a fairly controlled list of people, a controlled universe of people who should be getting the vaccine. I've heard a number of stories already about, due to the storage, the cold chain storage requirements, that, you go to a nursing facility and it turns out there are less people there than originally reported, and you have 5 vials left. And what do you do in that situation? And there's not a ton of guidance on what to do in that situation, quite honestly. So there have been reports that people who, don't neatly fall into 1A end up getting, cutting the line, so to speak, whether it's intentional or unintentional. And we have raised this repeatedly with the state. They have largely employed a honor code kind of approach to this. But unfortunately, we know that these systems can be gamed. And unfortunately, the people who game them often aren't people who are on this call, and the people that we do advocacy on behalf of. So it is an ongoing area of concern. I think the state is really open to ideas on what we can do to better monitor that. I mean, there's a tension here, to be honest, right? You want to put enough controls in place to make sure that everyone who is in the phase gets the vaccine, but you also don't want to overly burden people such that it's harder for them, even if they should be getting the vaccine, to get it in the first place. So I think that's an area where, if you have specific ideas on what would be helpful, what would make sense to you in terms of walking that balance, we would love to hear that. I'm sure your local health departments, in the midst of everything they're doing, they would welcome that level of feedback too. And if you do have specific ideas, and Russell will probably get to this, which is a good transition, because a number of us are on the Community of Vaccine Advisory Committee, we are really happy to take ideas back to that group and back to the state. We have some direct channels of communication. Whether they will listen to us is a separate question, but we are happy to really take good ideas on how that should happen in terms of like the monitoring piece, but also, what group people should fall into. We're really open to raising those issues in the channels that we have. So let me with that turn it over to, go ahead,
Well,
Sylvia.
I do want to raise, there's one more question I think is important. And that was a question about the urgent need for mobile clinic vaccinations. Someone is asking about COVID-19 vaccines for people with disabilities at home. They are a caregiver for bedbound seniors that are high risk and can't leave the house to get a vaccine.
Yeah, I mean, I'll say I think that's a huge issue. I'm not sure what the specific question was, but one thing that we talked about at the last meeting was the importance of making sure that people who are homebound either have transportation or other solutions. For example, if you are on the Medi-Cal program, technically your Medi-Cal plan should provide you transportation to covered services. And this, of course, is a covered, if not essential service. So that's one thing. Of course, how well that works in practice even before COVID is in question, but it's definitely on the radar for the state, and is going to be something that we need to really figure out, especially as we move into 1B, where we're reaching more people in the community.
And this is Christine. I just want to add, because of what Denny had said about the sensitivity and keeping the vaccine at a specific low temperature, having vaccines be given at home is something right now that is we're being told that that's impossible to do at this point, but that there are other vaccines that are going to be coming available that might not be the same temperature requirements. So the Johnson & Johnson vaccine, as an example, is another one, and that one might be able to be administered at home.
Yeah, there's just the refrigeration requirements, unfortunately, particularly for Pfizer. A lot of healthcare systems had to order special refrigerators to just store the thing, store the vials. So that's not stuff that's going to be readily available at home, and really will affect distribution. So I think now we can turn it over to Russell and keep going with questions in the chat and go from there.
Great, thank you. Thank you so much, Denny. Hi, everyone. My name is Russell Rawlings. I'm the statewide community organizer at California Foundation for Independent Living Centers and facilitator of the DO Network. The DO Network has been looking at this issue for quite some time, and I really appreciate a lot of the information that Denny has given you. What I'm going to share with you now is a toolkit that this entire team has put together. I am going to share my screen. Will someone please, who is not me, let me know if interpreters and other access remain available and visible while I do this. Okay, how do we look?
You look good.
We good? We still see captioners?
Yeah.
Okay, good. All right, so this is the Disability, Aging, and Higher Weight Communities COVID-19 Advocacy Toolkit, and this represents a lot of work from a lot of the partners that you see with you here today that you're going to hear from in the future on this call as well. The short link to this toolkit is listed right here. For those of you on the phone, I will read it aloud. It is tiny, T-I-N-Y, url.com/COVID, C-O-V-I-D, advocacy, A-D-V-O-C-A-C-Y, toolkit. And that will get you to this advocacy toolkit. And we will continue to look at this document and make updates as we see them appropriate. But the major outlines here, I'm not going to spend a lot of time in the actual details of this document too much. I'm just going to give you a very high level and hit some of the really important points. First of all, we have a section on vaccine allocation advocacy. We have a sample public comment that we've got a link to. It's an external link. We have the email address for the California Community Vaccine Advisory Committee. Some of the members are here on this call. Then we have a very helpful set of resources here. These are directories for sending comments to local vaccine committees or public health agencies. And I just want to spend just 1 minute here to really underscore the importance of doing your advocacy on a local level and making those connections to your county health officials and asking about local vaccine distribution or local vaccine advocacy committees, because a lot of what Denny went over is state level recommendation, but counties are allowed to implement in a variety of fashions. And as we heard earlier, some counties may be doing things differently. There may be some differences in the way that actual allocation occurs. So it's going to be really important to keep tabs on those. The next is a link to the California Department of Public Health, vaccine doses shipped and administered, and then finally a link to the Vaccine Advisory Committee. There are going to be ongoing public meetings, so please keep an eye on that website. And there is a link to California guidance on allocation for phase 1A. And then I am going to pass over to Brandy for a moment to describe one of two surveys. The first survey being from the Nobody is Disposable community survey.
Hi, thank you, Russell. Yes, my name is Brandy Senziak. I'm a fat, disabled, disability and immigration attorney. I'm supervise the legal program at Independent Living Resource Center, San Francisco, and I'm the legal director of FAT Legal Advocacy, Rights and Education Project, and the supervising immigration attorney at Justice and Diversity Center's Homeless Advocacy Project. I'm also one of the core organizers of the Nobody is Disposable Coalition. So yeah, thank you, Russell, for speaking about our toolkit and introducing it. The Nobody is Disposable Coalition created a survey to basically ask for stories and statistics of individuals that are fat, disabled, or people of color that have been putting off medical care and medical testing, which are in some cases are, life saving medical testing and medical care that is really important to be done because they may be at a higher risk of complications if they were to get COVID. Many of these people would also possibly face discrimination in a crisis care situation based on being fat or based on a disability. and also, unfortunately, many of these people are not on the state's high up on the state's priority for receiving the vaccine. So we're really worried, obviously, about folks not being able to get the medical care that they need and to do the medical testing that is important for them to have done because of discrimination they'll face and not being a priority for the vaccine. So we're going to do hopefully some advocacy around the vaccine. And in order to do that, we have created a survey for individuals to complete. And so if you are in this situation and are would like to share your story, or even if you don't want to share your story and you just have statistics that you would like to share with us, please fill out our survey. If you know someone, please pass the survey along to them. And if you don't know anyone in the situation, but you just want to get the word out, if you can share the survey on social media, that would be great as well. You can find the survey on the toolkit, as Russell mentioned, and you can also go to our website, which is nobodyisdisposable.org, and a link to the survey is there as well. So thank you very much. Back to Russell.
Thank you, Brandy. And then immediately following, we have our CFILC COVID-19 Disability Community Vaccine Survey, which is a very high-level survey and just represents a very quick snapshot of general opinions about the vaccine. We are trying to collect data to also do some vaccine advocacy, and we'll be collaborating in the future and bringing that information to this group as well. The next section of the toolkit focuses on the second piece that this coalition has been working on, which is the crisis standard of care advocacy. And there is a good number of know your rights documents here. And following that is a list of visitation advocacy resources also. So the other issue that we've been tracking is folks being able to go in and support people with disabilities in settings during this time. There's also a list of resources for visitation advocacy. And then finally, the final most important part of the toolkit for today's purpose and immediate use are the sample social media posts. And we have a number of hashtags that we've developed and some sample social media posts that are really helpful. Well, the first one's targeted directly at hospitals and asking what their crisis care plans are. We also have a link to this toolkit and some personal story. And feel free, of course, to use these hashtags as well in your own personal story. So there's quite a comprehensive toolkit here. I do want to turn the agenda back over so that we can get through our final items. I am available though via email at info@disabilityorganizing.net, and would love to hear from folks who are particularly interested in county and local level advocacy. If you're willing to contact your county local public health officer, I'd love to be in touch with you and try to help organize. Thanks.
Hi, it's Claudia Center again with DREDF, and I'm going to do a short overview of the state of California on crisis standards of care, which is becoming increasingly pressing throughout the state, and particularly in Southern California. So big picture, the principle that our communities are bringing to crisis standards of care is that civil rights laws, state and federal civil rights laws, still apply during the pandemic, and they apply to healthcare rationing and crisis standards of care. So those laws prohibit discrimination on various bases, including age, including disability, and including race or ethnicity. in terms of statewide or federal-wide laws, they do not include higher weight as a protected status, but higher weight is very intertwined with disability or perceived disability, very intertwined with race and disability, the intersection of those two statuses. So in many ways, people with higher weight are protected by laws because higher weight is a proxy for these other types of protected statuses. So that is sort of our principled way of approaching crisis standards of care or triage. The sort of painful reality, though, is that crisis standards of care means that there's not enough for everyone. So sort of the painful and preventable reality that happens with crisis standards of care is that people who are more likely to survive in the short term, meaning more likely to survive hospitalization, more likely to survive a few months after hospitalization, are prioritized over people who are less likely to survive hospitalization or a period after hospitalization. And sort of the uneasy balance between equal rights and shortage is that that is probably considered lawful. It's sort of a balance between triage and non-discrimination. So even if somebody is, you know, the reason why they're less likely to survive hospitalization might be something protected, that's still considered you know, lawful given the shortage, because the idea is that it is a lawful goal to try and save as many lives as possible. When the first guidelines came out in California in April, they were really terrible. They discriminated on the basis of age and disability. And so a huge coalition of people, including many people on this call, advocated to get improved guidelines, which were published in June of 2020. And let me just talk a little bit about what those guidelines say. First of all, they explicitly state that there can be no discrimination in crisis standards of care. So not only in the June guidance, not only is that based on all of the protected statuses that are in our state and federal laws, but the state guidelines from June include explicitly weight, size, socioeconomic status, perceived quality of life, immigration status, incarceration status, homelessness, past or future use of resources, ability to pay, and so on. So the guidance takes our the statuses that are in our state and federal laws, but then also adds a number of additional important statuses to the list of criteria that should not be the basis for rationing. The guidelines also make it clear that people with disabilities are entitled, older and disabled patients are entitled to reasonable modifications. And that would include to triage scoring systems. So a common triage scoring system is called the SOFA. And some people might score more poorly on the SOFA due to a pre-existing disability that does not indicate that they are not likely to survive hospitalization. And so as a reasonable modification, their score could be adjusted. And so that's in our guidance. Or someone with a disability might need a longer trial on a ventilator or a medication trial, and that longer trial might be a reasonable modification. So those are some of the very important aspects of the June 2020 guidelines. And the guidelines also say that if there's a tie, if they use the SOFA score and there's a tie and there's not enough resources for everyone and they have to use a tiebreaker, they can consider whether a person has a severe life-limiting condition likely to cause death in the very near term. And the example given is a person with metastatic cancer who is expected to die within 6 months, even with treatment. So, that's kind of the where we ended up. We advocated against that tiebreaker, but it's much better than other states. And the document makes clear that you cannot reallocate personal ventilators. It makes clear that you cannot weigh things like quality of life or something called life years, which goes into life expectancy or how old you are, and is another way to discriminate on the basis of age and disability. So those are kind of the high points of the June 2020 guidance. Now, of course, we have many, many hospitals and hospital systems, each of which may have their own crisis standards of care. And so in December 28th, 2020, the state of California published a new implementation guidance that requires that all hospitals, acute care hospitals, publish their crisis standards of care and send a link to the California Department of Public Health by January 6, 2021. And CDPH is supposed to get our communities those links. We don't have them yet, but once we have them, we will be starting a process, including volunteers, to review those policies and to see where the red flags are. So that is sort of the fast overview of formal or, on pen and paper rationing during the surge. And Brandy is going to talk a little bit about what we sometimes call soft rationing, or kind of behind the scenes rationing, under the radar rationing.
Thank you, Claudia. Yes, so I would like to talk about a policy that was issued January 4th by Los Angeles County regarding EMS. So on January 4th, as I said, Los Angeles County issued a policy, which the Los Angeles Times reported on. That basically ambulances should not transport patients to emergency rooms if they have little chance of survival. We're really concerned that this is just another way of rationing care, and that it is unlawfully puts life-saving decisions in the hands of care providers without giving them the proper tools and training and resources. People have a lot of prejudice and also a lot of misinformation about fat, disabled, BIPOC people and COVID survivability. We are worried that with these unlawful and this could create unlawful and unfair discrimination. So as Claudia was saying, healthcare decisions in California regarding rationing cannot, and the allocation of scarce resources cannot be based on age, race, disability, including weight-related disabilities and chronic medical conditions, gender, sexual orientation, gender identity, ethnicity, including national origin and language spoken, ability to pay, weight, size, social economic status, insurance status, perceived self-worth, perceived quality of life, immigration status, incarceration status, homelessness, or past or future use of resources. So if you are someone who's an emergency service provider who is feeling pressured into refusing care, or if you're a patient who is facing a refusal of transport to a hospital for discrimination reasons, try to not lose hope. Remember that nobody is disposable. We are worth fighting for. You can reach out to nobodyisdisposable@gmail.com. Or go to our website. And also, I believe there's a link on the toolkit as well. Or you can also call local disability rights organizations in your area. In addition to that, I wanted to mention what Claudia was talking about as far as the hospital's guidelines and the hospital's policies regarding crisis care. There's over 400 hospitals in California, and all of them could potentially have their own policy. So with this being said, we may need volunteers to help review these policies. We really want to try to make sure that the policies at least keep the standards of the California crisis care guidelines. And so if you are an attorney or someone that has policy experience or someone that is in law school and you're interested in volunteering to assist us in reviewing these policies, please reach out to us at nobodyisdisposable@gmail.com, or you can also go to our website, and I believe the link is also in the toolkit. If you are someone that's reviewing these policies or your hospital policy on your own, I think a good place to start and a good way to review this policy would be to pull up the California Department of Public Health crisis care guidelines and sort of compare it to the policy of your hospital, and just to make sure that you won't be facing discrimination based on one of those categories that myself and Claudia just spoke about. So thank you so much, and back to Claudia.
Hi, this is Claudia, and I think, let's see, I think Jessica, were you going to talk a little bit about advocacy?
Yeah.
Yes.
Okay. Hi again, everyone. This is Jessica. So wanted to talk a little bit about how community members can get involved if we need to push back, right? That's what we did at the state level to get better crisis standards of care in California, better guidelines for what hospitals, what criteria they should use so that it wasn't them using age, disability, weight, race, etc. And there is so much going on. We need to follow up with individual hospitals now. Because things are moving so quickly, we don't have a super clear action step right now that we want everyone to do. But I do want to say a couple things about things to think about, right? So Brandy talked about looking at your local hospital crisis care policy. If it's not posted on their website, which we haven't found yet, you can call your local public health department and ask them. You can call the communications or public relations person at your local hospital, which should be relatively easy to find, I hope, and ask them where it is. Let them know that the state requires it and that you want to see it. If you have a specific issue, please contact any of our organizations. I would recommend starting with Disability Rights California and Disability Rights Education and Defense Fund, DREDF. And that information is in the toolkit, and we will email that out as well. If we do identify hospitals or hospital systems that have discriminatory crisis care guidelines, we are going to want to come together and push back. And people have said, well, if they are not great guidelines, but they have put it out there, which is their legal responsibility, why would they fix it, right? What legal responsibility do they have? That's questionable. There are a lot of legal arguments to be used here, but from an advocacy point of view, it's about people power, right? It's about the number of people who are pushing back to say we are in a pandemic and our communities are important and that they need to do the right thing. And that has brought about a lot of change. So do not forget that it can bring about change now. So in the toolkit, we have a number of social media posts that you can use to tag your local hospital and say you need to not discriminate against older people, against higher weight people, against disabled people, and that there's a huge overlap with Black, Indigenous, people of color as well. You can call them up and say, you need to fix this, right? You can reach out to your friends and your networks and ask them to make calls and send letters and do social media. And let's stay connected, right? Because if there is a hospital system that we find is not doing a good job with their crisis care guidelines, then we need to make sure we're putting the word out so that we can all put pressure on them to fix it. Thank you. I think that covers it.
Thank you, Jessica. Sylvia, I'm having trouble reading the chat on my end. Could you read the question or call on the person who had the question?
Hello, this is Sylvia. I'm looking at Jeff. You raised your hand, and I'm just looking, trying to get the. You had a question that I think it was a question that said first shot, get a card from CDC setting 3 weeks second shot, but can wait. Is there a question that you wanted to raise, Jeff? And
Sorry, I'm also listening to Dr. Galway on Health and Human Services. Just passing the information on people is that when YOLO's being very good about getting the first shot out, they give you a CDC card for validating them. When you get the shot, you have 3 weeks and later, and that is Modena right now, is the vaccinations that are being utilized there. And the other thing I was alerting you to, in Los Angeles, there is a serious dispatch problem for ambulances to getting to hospitals and getting admission. It's just a heads up, not so much a question, just a heads up right now. You guys can verify it. It's down there. One of the facilities is at Beverly Boulevard, and oh, I don't remember exactly where it's at in Los Angeles, but they are overwhelmed in trying to get ambulances to get people. It's why you hear about the portable morgues now going into Los Angeles.
This is Claudia. Thank you, Jeffrey. We've had a few comments in the chat asking, where do you find the requirement that hospitals post their crisis standard of care guidelines? How do we find it? And we have posted in the chat, and it's also in the toolkit, the link to the December 28 document that requires the posting of the guidelines. We're not sure how much compliance there is yet. We think probably not perfect compliance. CDPH has promised to get us the links, and we need to circle back with them to get them, and then we will do the review with our volunteers and the community. Sylvia, were there other questions in the chat about crisis standards of care before we move on to visitation?
there was just one more that was asking about that very thing. What happens to hospitals or facilities that don't post their crisis standards of care by next Wednesday, or the time they're supposed to post it?
The deadline has already passed. It's June 6th. So they should have already posted their guidelines. If we discover a hospital that has not posted, we will report it to the state of California, and we will do everything we can to push the state of California to require the hospital to share and post as they've been directed to do. And we'll also reach out to all of you to use social media to push the hospital to do what they've been directed to do.
And also, Claudia, again, we are looking for volunteers that are willing and able to help locate these policies on the different hospital websites. So please email nobodyisdisposable@gmail.com if you're interested in volunteering to do that.
Okay, if we don't have more questions on crisis standards of care, I'm going to turn the meeting over to Will Liner, who's going to talk about visitation.
Thank you, Claudia. And hi, everyone. My name is Will Liner. I am an attorney with Disability Rights California. I'm grateful for the opportunity to talk to all of you today and for all of you for being here. I'm going to give a general overview of hospital visitation restrictions and some really troubling things that we're seeing on the ground. And then my colleague, Nick Levenhagen, is going to talk about what all of you can do if you encounter discriminatory policies and practices at hospitals about visitation. We all know that hospitals across the state have been restricting visitation since the start of the pandemic in an understandable effort to prevent community spread. But in doing so, we see that many hospitals have also forgotten that non-discrimination laws apply to hospital visitation, those same non-discrimination laws that Claudia discussed earlier today. And here we're going to talk more specifically about the obligations of hospitals under anti-discrimination laws like the Americans with Disabilities Act to modify visitation policies so that patients with disabilities can receive equal access to care and treatment. But before we get into that discussion, I wanted to have a brief discussion about the terminology we use to discuss this issue and the difference between visitor and supporter, including who can be designated as a supporter and examples of how supporters can help. Because really, while we're centering this conversation around hospital visitation policies, we're not really talking about visitation or even the rights of visitors. We're talking about the rights of patients with disabilities to have support persons so they can have equal access to care and treatment. Some people make this about social hour, but this isn't about social hour. It's about equal access. And when we talk about visitors or supporters, we're not just talking about immediate family either. A support person can be anyone who can assist a patient with a disability meaningfully access care and treatment at the hospital. This could mean communication supports, mobility, emotional supports, personal care, and other activities of daily living. It can mean a paid personal care attendant, a family member, a partner, or a less formal caregiver. The point is that the definition is broad. And again, we're centered on what it takes to provide people with equal access. I want to just spend a couple of minutes giving a few examples of what this could mean in practice. It could mean a patient with a disability-related communication barrier that requires the in-person support of a trusted person to facilitate effective communication with healthcare staff. It could mean a patient with a disability that affects their ability to understand or follow medical guidance and may need a trusted support person to assist them. And I've also say we've seen some terrible examples where a person's disability can lead to agitation or fear, where the absence of a trusted supporter means they can't access their medical treatment, or they would suffer from a severe intervention in the absence of a supporter. We've come across examples where doctors have suggested inserting feeding tubes into people for nutrition when a prompt from a supporter to eat would suffice if they're allowed in the hospital with them. We've seen instances of people being put in restraints so that they can be administered oxygen through a mask, when again, a prompt from a trusted supporter for that person to keep their mask on would suffice in that situation. So this is what we're talking about when we talk about visitation and supporters and what functions supporters can provide. And I want to talk a bit about what the state visitation guidelines say. Russell and Jessica both pointed you to the toolkit with a lot of information and resources. The California Department of Public Health visitation guidelines are part of those resources. And I want to quickly talk about what's good in that document, what's not so good, and what's probably okay. One of the good things about the California Department Public Health guidance is that it covers a range of circumstances where visitation exceptions should be made. Not just about people with disabilities, but also about pediatric patients, labor and delivery patients at the end of their life. There's a strong recognition in that document that visitors and support persons are really one and the same and can be used interchangeably, recognizing the vital role that visitors play in the well-being and recovery of patients. And there's a strong recognition that the presence of support persons are essential to patients and patients with disabilities. But there's some questionable things in that guidance as well. For whatever reason, the visitation exceptions in that guidance only apply to a limited subset of people with disabilities. I'm going to read it so I get it right, but it applies to patients with physical, intellectual, and/or developmental disabilities and patients with cognitive impairments. That's a much narrower subset of people that can be considered as having disabilities under non-discrimination laws. And in our view, no reason why these visitation exceptions shouldn't apply to all people with disabilities. The guidelines also discuss visitation in terms of medical necessity and not equal access, which confuses the issue a little bit because, again, there's no discussion of the application of non-discrimination laws to hospital visitations. And there are some things in there that are, okay, probably around the obligations of supporters and visitors when they are permitted access to the person in a hospital, restrictions like one person at a time, visitors being subject to screening for fever or COVID-19 symptoms, requirements that people wear face coverings upon entry and other personal protective equipment while at the hospital and in the patient's room. And there are other restrictions around limiting the ability of someone to just kind of walk around the hallways in the hospital as well. So we see, because of the, I'll say, different holes in the guidance in that way, we see common problems with hospital visitation policies as they're written or on the ground in practice. We see some hospitals that still don't have public exceptions that can be made for visitation. We see when there are exceptions made, those exceptions only apply to patients with intellectual and developmental disabilities. We've seen hospital policies that place restrictions on the locations in which a supporter can be present. For example, in the emergency room is okay, but once someone's admitted to an inpatient unit, then it's not okay for a visitor or supporter to be present. We've seen hospitals that will rely on what they call sitters as an alternative to a supporter, essentially someone that sits outside the door in the hospital, that sits outside the door of a patient's room that could then alert a nurse if something is going on, as if that's the same type of thing as a trusted supporter in the room. And then we see decent policies that aren't implemented at the frontline staffing level, where there's a disconnect between a policy that looks pretty good, but not appropriately rolled out, where staff haven't received training on what those policies mean. So people undergo unnecessary and troubling delays as they're trying to advocate and access the patient for whom they seek to visit. So these are a lot of the things that we're seeing on the ground. And I know we're running short on time, so I want to turn this over to Nick Levenhagen, who's going to talk about how people can advocate for themselves and what to do if they encounter discriminatory policies or practices around hospital visitation.
And before Nick starts, this is Claudia. I just wanted to say, if you put your questions in the chat and we run out of time, we will answer them offline.
All right, thanks so much, Will and Claudia. Hi, everyone. My name is Nick Levenhagen. I'm an attorney with the Healthcare and Home and Community-Based Services team at Disability Rights California. Wanted to spend a few minutes talking about actions that can be taken for situations where a support person is denied access by a hospital. First, in the toolkit that's being discussed today, there's a link to a draft of a template letter that can be used in advocating for access of a support person to the hospital. This letter includes sections where you can fill in the description of an individual's support needs, provide some suggested language regarding what those needs may be that you can use or choose to delete and edit how you like. It includes a discussion of civil rights laws requiring that hospitals permit access of a support person, as Will just discussed, including that reasonable modifications to COVID-19 visitation restrictions are required by the ADA, Section 504, Section 1557 in California state law. It also includes links to the guidance provided by HHS and the California Department of Public Health, and an area where you can include a link to the hospital policy if that policy is available and already states that a support person should be allowed as an exception to any COVID-19 visitation restrictions. And the letter includes a commitment that the support person will comply with reasonable hospital PPE and safety protocols as required by the CDPH guidance, like wearing a required mask, staying in the patient's room except to enter and exit the hospital and use the restroom, and following other reasonable protocols. DRC's received a number of calls regarding hospital visitor policies throughout the pandemic. And we started providing callers with a similar template letter, and I've heard back from folks that it's helped successfully resolve the issue in some cases. So I think using and providing this letter is a good place to start. If you require a support person or are a support person for another individual, it may be a good idea to start creating a draft of this letter now and bring it with you if you need to visit the hospital for any reason. DRC and DREDF also have a publication available on our website addressing COVID-19 hospital visitation policies, and the link to this publication is also available in the toolkit. And it can also be found by going to the main page on DRC's website and clicking on the COVID-19 information box under our featured content section. This section also includes publications on the crisis care guidelines, changes to medical IHSS rules during COVID-19, and a number of other topics. This publication discusses your legal rights to a support person, information on where you may file complaints if you encounter a problem, and a link to the state guidance and a guidance document that DRC and DREDF drafted for healthcare facilities, which is also included in the toolkit. And it may be helpful to bring these documents to the hospital with you in addition to the template letter. If a hospital continues to deny entry to a support person despite this information, you may wish to escalate the request and seek additional legal help. If you're an advocate, we should note that our organizations have had success in some cases by contacting the hospital's legal counsel if you're able to get their contact information. If an advocate is needed, you can contact one of our agencies to request assistance. Disability Rights California's intake line is available from 9 to 4 on weekdays, and you may leave a message outside of these hours. The contact information is also in the toolkit, but quickly, our number here is 1-800-776-5746 or TTY 1-800-719-5798. And you can also contact us through our website at disabilityrightsca.org/get-help. And you can also contact DREDF by phone 510-644-2555 or TTY 510-841-8645, or by email at info@dredf.org. And this information is in the toolkit as well. If the hospital continues to deny access to a support person, or even if the situation is resolved and you'd like to file a complaint about your experience, you should consider filing complaints with state and federal agencies. For California, you may file a complaint with the California Department of Fair Employment and Housing. The link is included in the toolkit. If you are or advocating for a Medi-Cal patient, you may also file a complaint with the Department of Healthcare Services Office of Civil Rights. I should also note there is a way to file a complaint through the California Department of Public Health, who released the state guidance on this issue. However, we did try filing a series of complaints with them earlier this year, and we're informed there are some limitations to their jurisdiction to enforce civil rights laws for cases like this. So just so you have it, that is a complaint you can file. And then for federal complaints, you may file this through the U.S. Department of Health and Human Services Office of Civil Rights. So all this information is in the toolkit, and certainly please feel free to contact us with any questions or concerns. Thanks so much.
This is Claudia. I'm going to turn the meeting over to Christina Mills to close our meeting. Christina is with the California Foundation for Independent Living Centers and is a fantastic advocate for disability rights and is always fighting for our communities. So thank you, Christina.
Thank you, Claudia. I just want to absolutely give lots of thanks to everyone who joined today. We do hope that you've appreciated our community coming together. We feel that it's very important that people with disabilities and older adults are presenting this information about us, with us, and for us. And I want to thank DREDF, Disability Rights California, San Francisco Senior and Disability Action, Choice and Aging, Justice and Aging, CFILC, our Disability Organizing Network program, the Nobody is Disposable Coalition, Independent Living Center San Francisco, as well as the Care Crisis Standards Coalition. As you can tell, there are a lot of things happening in California, and everyone today mentioned a number of ways that you can take action. We put a lot of information and resources into the chat. We will have a recorded Facebook and Zoom archive for all of you to view if you've missed any of it or would like to share it. We have surveys that you can take. We have sample social media. We have volunteerism that we're looking for folks to sign up for. We have a wonderful toolkit that we'd love for you to make use of. And we'd like you to tell us, what are we missing? What do we still need? And how can we assist and help the community in making sure that, like we've talked about throughout today, how do we make sure that our communities are elevated and not forgotten in any of the issues that we are dealing with in COVID, as well as the other issues facing our communities because of the economic situation that we're in. We really want to encourage folks to not only attend our statewide community vaccine committee meetings, but to also attend as members of the public your county committees, and more importantly, provide public comment and ask the hard questions. Ask where people with disabilities and older adults are being prioritized in your specific community, how the implementation process is happening. And with that, we hope that you will join us again and provide us feedback. Thank you for joining us, and thank you for our sign language interpreter, as well as our captioner. Have a great weekend, everyone.